Hi everyone, welcome back to GoggleDocs. This is our weekly roundup and catch up with the guys, and we're just going to be having a chat of what's caught our eye in the last 7 days. So let's go around and introduce ourselves very briefly. So we've got Kevin.
Hi everybody, Kevin Fernando here, GP partner at North Berwick Health Centre, just east of Edinburgh.
And Amar.
Hi everyone, consultant diabetologist in the West Midlands.
And Patrick.
GP partner in Darlington, north of England.
And I'm Amrit, GP in North London. So welcome back, great to have you with us. So guys, anything that caught your eye in the last 7 days that you want to discuss?
So again, I read a lot of the papers, but one of the articles that I saw was in a journal called Circulation, and it was looking at people who had gestational diabetes. So we know that gestational diabetes is a risk factor for developing type 2 diabetes in the future. And so that metabolic risk is there and persistent over the lifetime, subsequent lifetime. What this looked at was actually looking at something called CT calcium scoring to look at cardiovascular risk in those people who had gestational diabetes. And it was a long-term follow-up. It was done in America. It was about 25 years or so, where they looked at people who had gestational diabetes, and then had follow-ups over the course of the next 25 years, where they had glucose tolerance tests and they had CT calcium scores. And essentially what they found was that even in those people who had reverted from gestational diabetes to normal glycemia, as they called it, the risk, their calcium score was higher than those who didn't have gestational diabetes. So essentially what they were saying is that even if you revert back to normal blood sugar levels, the cardiovascular risk persists even beyond and 25 years down the line as well. So it got me thinking about, actually we focus on the gestational diabetes and type 2 diabetes screening, but should we also think about this cardiovascular risk as well? And I'm getting interested from your sides, what, firstly from the gestational diabetes, this yearly kind of HbA1cs, how does that go with yourselves? And also, where does this factor into that if it does at all?
Oh, it's very, very important. It's very relevant to us in primary care, and just hammers home how important it is to follow up women who have had a diagnosis of gestational diabetes. And I'll put my hand up first. A lot of these women in my practice have been lost to follow up in the past, and it's unsurprising, busy family, new family lives, and big busy practices. But as you pointed out, the NICE diabetes guideline was quite clear, wasn't it? All women with gestational diabetes need at least an annual HbA1c, perhaps even more frequent in high-risk populations, South Asians, for example. So yeah, that just hammers home to me the lifetime cardiovascular risk, which you mentioned, but also that lifetime metabolic risk. And in fact, you probably saw that Leicester paper from last year, high quality systematic review meta-analysis, essentially telling us women with gestational diabetes have a 10-fold increased risk of developing type 2 diabetes in their lifetime. So absolutely, we need to be coding gestational diabetes accurately, and we need to be following up these women regularly. So yeah, I think very important paper for us all in primary care.
Yeah, it's interesting. I think there are certain systems that need to be put in place within primary care for there to be an annual reminder. And as you say, Kevin, if it's not coded, then that will certainly slip through the net. But I think there's also a role here for the women themselves, obviously, who are diagnosed with gestational diabetes, to be counseled appropriately, not only in terms of the risk of developing diabetes, but Amar, as you say now, to also be aware of the cardiovascular implications, regardless of glucose control. So I think there's a joint effort there, really, isn't there? Often when it comes to disease prevention, it falls on both clinician and patient, both.
And I suppose the traditional handover, I mean, we still do the 6-8 week checks, but when I'm back in the day, I remember we used to literally do home visits on all these families, but yeah, there is a bit of a disconnect perhaps between the specialist care, because typically that's where their diabetes care is happening, and then that handover, they just disappear if we don't chase them up. But it sort of underlines, I think there's this growing evidence base that developing diabetes at a young age you know, and we are obviously talking about pregnant women, so that we are talking a young age. It really, you know, this is a different beast from, you know, I don't know, the pre-diabetes that we're seeing, or the non-diabetic hyperglycemia we're seeing in, you know, people in their 60s or 70s, where yes, they may develop type 2 diabetes, but they're not going to get the harms that we see with a younger diagnosis. Do you want me to talk about the paper which caught my eye?
Absolutely. Go
yeah, yeah. So it's not perhaps a new paper, but I think something which is of growing importance. So this was a meta-analysis and systematic review published in Primary Care Diabetes, and it was about metformin and the risk of cancer amongst patients with type 2 diabetes. And and what do they do? Well, I suppose before that, you know, what's the link there? Well, we know insulin resistance and inflammation can increase the risk of cancer. Some of that may be related to hyperinsulinemia, high levels of insulin, which stimulates insulin-like growth factor. There's also some evidence that metformin may actually upregulate certain pathways, which in turn downregulate mTOR, which is a cellular growth factor, which affects a number of tumors. So there's some rationale that type 2 diabetes is a high risk condition, and metformin may actually help us. Anyway, and there've been other meta-analyses in the past, but they did, I think, a reasonable job in certainly looking at lots of studies. 67 studies they looked at. A total of over 10 million people with type 2 diabetes were included in those studies, and over 145,000 people with cancer. So there's quite big numbers. And they looked at never users of metformin versus users of metformin. And it's observational data. So there's a big caveat there about, you know, how valid this data is. It really should be generating studies, but who's going to be doing a randomized control in cancer? Although, well, to be fair, there are some studies going on that, I think, particularly in breast cancer. So we'll get more information, but at the moment we haven't got any large RCTs. So the top line was overall there was a 30% reduction across a broad range of cancers. The ones which they highlighted, there was clear benefit that was in reducing bladder cancer, colorectal cancer, esophageal cancer, head and neck cancer, lung cancer, prostate cancer, and pancreatic cancer. Oh, and liver cancer. So there's quite a lot of cancers there. Yeah, so I thought that was useful, and it reminds us how important, even we've got these newer agents which are really great against cardiovascular disease. I still think the jury's out about metformin and cardiovascular disease, but there are other benefits in terms of weight loss and in terms of perhaps cancer reduction.
In fact, that's what I was going to mention. I'd be interested to see a bit more data about the weight loss and the metformin and cancer risk, because metformin essentially, I know it's essentially weight neutral, but we often do see some weight loss, don't we, with metformin, and we know tragically obesity is a risk factor for about 13 or 14 different cancers now, including many of the ones you listed there, Patrick. So I wonder if that's a potential confounder. Do you know if they explored that in the paper?
That's a fair question. I think that was explored in the studies before, but they didn't do I couldn't see a specific analysis on that. I mean, I think obviously there's a huge overlap between insulin resistance and obesity. So you're absolutely right. It is a complicated picture, and weight is a factor. As we do, I suppose, just going back, one little throwaway fact, I sometimes, to motivate women to breastfeed, we know that reduces the risk of, or there's observational data which shows that reduces the risk of breast cancer, presumably through the weight loss associated with breastfeeding.
Yeah, cancer is certainly something worth bearing in mind. We've got even just recently mortality data showing that the all-cause mortality in diabetes, cancer deaths are on their way up, accounting for just over a quarter of all deaths. And the cardiovascular picture, which we know is a major leading cause of death in diabetes, is is starting to reduce ever so slightly. But so cancer is certainly something important for us to all kind of keep in mind.
There's just one other little cancer nugget that just came to mind actually on pancreatic cancer. I did a little piece for Primary Care Diabetes Society last year, and the figure that struck me there was post-pancreatitis diabetes. So, your patients who have had a history of, say, chronic pancreatitis and then develop diabetes as a result of that, they have an 8-fold increased risk of pancreatic cancer. So that really struck me there. So perhaps, we should be paying a wee bit more attention to our patients with a history of chronic pancreatitis, which is a risk factor too, but particularly those who go on to develop type 2 diabetes, and look for early changes in LFTs, for example, or safety net about jaundice and other symptoms. So cancer and diabetes are often sadly in the same sentence, aren't they?
I'm going to temper this metformin love in by just saying, is metformin at risk of becoming the vitamin D of becoming that vitamin D in a way rather than vitamin D of the world? It's been implicated in so many things, metformin. I mean, we had cognitive impairment improvements last year paper. We have cardiovascular disease, possibly, you could argue that. We have cancer that's been there, and a number of other things that have come and gone. So, a lot of this is observational, as you say, it's kind of reviews of things. There's nothing kind of direct hard evidence for it. And yeah, I mean, it just constantly comes up, and what do you say with that?
Amar, what's the public health advice for vitamin D? Just take it. Did we just say the same about metformin?
I mean, obviously there's huge, it's always difficult when you're comparing these things in observational terms. I mean, in the sense that obviously if you've got significant renal impairment, we know you're not going to be prescribing metformin probably. If you've got, going back to your pancreatic, the type 3C diabetes, with patients who've got diabetes related to pancreatic disease, they generally are not on metformin. They're probably having some GI issues related to the pancreatic disease, which maybe, and we're often not quick at diagnosing that condition. Yeah. So, but they often end up on, they end up on insulin, and again, that might feed, just if you believe this whole hyperinsulinemia as the cause for one of the causes for potential, then are we causing more harm by potentially? I don't think there's any alternative for those patients, but it's apples and pears, aren't we, when we're comparing often these with observational studies, and it's so yeah, there's a big health warning on that one, but I thought it was interesting.
I'm going to sidestep papers and just talk about some experience just in the last week with the COVID vaccine hub that we have locally. And I just thought something quite topical there. So I was helping out last Friday, I think it was. We were having a bit of a lull towards the end of the day. So I got on the phone and started calling patients who hadn't responded to their text message invitation. And I was there for about 2 hours. Now, I'm no stranger to rejection, but within those 2 hours, I think I only managed to book.
Oh, I've seen them.
So, but on a serious note, that really highlighted to me that the patients that were on that list who had not responded to their text message invitation were mainly from ethnic backgrounds, and we are starting to see, although we had a very kind of successful kind of initial kind of phase of vaccination in the older population. As we come to the younger age groups, there does appear to be some vaccine hesitancy. And this is something that's been commented a lot in many of the journals and medical press as well, particularly with the ethnic minorities. I know there's some longitudinal studies, there's some preprint at the moment that, that also identified older patients more likely to take up the offer of the vaccine. Younger patients, especially from ethnic minorities, less likely. Why is this? Perhaps the mistrust, the misinformation. A lot of the people I was speaking to on the phone were concerned about safety of the vaccine. They're worried that it's been rushed through. But my concern here is that this is a cohort of people, younger people, more likely to be moving around, therefore more likely to possibly be the people who will transmit the virus, but also from ethnic backgrounds. These are our patients who are more likely to have chronic disease, diabetes, cardiovascular disease, the same conditions that give you a greater risk of mortality with COVID-19. So a real concern there, and I'm interested to see how we're going to go about tackling this problem. And interested to hear your experience locally as well, what you found.
Certainly in my practice, I've got a largely Caucasian practice population and very elderly. Over 25% of my list size is over the age of 65. And we were just discussing we've had over 1,000 over 75-year-olds to vaccinate, huge number. But there's been no hesitancy. They've all been desperate for the vaccination. We've had to bolt the doors shut. Wait your turn. So look, I'll be jesting there, but no, what you mentioned, Amrit, is very potentially very serious with significant sequelae, isn't it? If we don't engage with our ethnic communities and encourage them to get vaccinated at the earliest opportunity.
Yeah, I mean, my story is the same, I think, as Kevin. Darlington is pretty white in terms of, it's not just when it snows here. We're pretty much all year round. So, but there's been huge enthusiasm by older people. I think I was just actually, we've now obviously our health staff have been vaccinated, and all but one member of staff is, and that's a young woman who wasn't vaccinated, who chose not to be vaccinated. So I think that we've so I think once we go to younger age groups, I think we're going to find more of an issue. And then but it's one thing which has been heartening is really, certainly in the diabetes community and beyond, but there's been a huge move by, people from whose ethnic background is not white European. They've come out in droves, really just trying to get the message through in whichever native language they're from, which has been great. I mean, I've seen it on various forms of social media. I think some of these things have been picked up by mainstream media as well. So hopefully the message is going to get through. But yeah, in Darlington, we're fighting them off. We haven't got a problem of getting people to the vaccine. Quite the contrary, we're doing our best to try to temper the enthusiasms of the ones who haven't been called yet.
I think you're just saying it's how you address that is the key thing, and it's kind of getting those figures of perceived authority or perceived seeing it, kind of embrace this and then kind of highlight that. And that's what you're saying. You've seen it within the diabetes community with a lot of our colleagues, but also across, I think, I'm glad to say that a lot of NHS, seeing that a lot of the government are realizing the importance of this and trying to highlight that with, from speaking from Birmingham, where we've got a multi-ethnic population. There's a lot of kind of initiatives. I know my friend's part of the Sikh Society, and he's doing a lot of work and with the Gurudwaras and things. He's getting involved there to kind of highlight this. We've got mosques, which have also now been centers for vaccinations, and temples, where they're trying to highlight this and trying to kind of show this. I think that's the right way forward, and it remains to be seen, how that progresses over time. I think we need to continue with this. But I'm heartened to see this. We've acknowledged this, and it's constantly being acknowledged and trying to work towards finding a solution to.
Yeah, absolutely. Quite a few of the temples locally have developed kind of videos. I suppose it's about. I mean, yes, there's certainly lots of people kind of making statements, making videos. People in the media who have got high profiles, but it's about that message still getting to those hard to reach people. And I think that's the challenge, how we actually get that message to those kind of people who are otherwise relying on social media, potentially relying on what other people around them may be saying. And so that's the battle, essentially. And it's just interesting that, locally, we've got a slightly younger population. So we've kind of started moving into these challenges. And I'm just thinking about the annual flu vaccine campaign. And the under 65s, generally, the uptake is a lot poorer than in the over 65s. And I think we may start seeing those similar sorts of figures showing. And so how we emphasize the importance of reaching these kind of vulnerable people, essentially, is going to be really interesting, and something that just needs to, essentially, the responsibility of all of us. Brilliant. All right, guys, I think we covered quite a few different things there. And now it's time for the meme of the week. And today it is of the legend that is Chris Whitty.
I mean, Chris Whitty is a legend, Professor Chris Whitty, isn't it?
Yeah.
And I wish I could see him in that attire in the near future. I'd pay top dollar for that.
Thanks for joining us, everyone, and we will see you soon. In fact, next week we are launching our heart failure mini-series, so please do tune into that. We're going to be going through everything we feel you need to know about heart failure in diabetes and beyond. So we look forward to seeing you then. Take care. Bye.
Bye.
Bye-bye.